The MIC is a value which tells us whether a microorganism will be sensitive or resistant to a particular antibiotic. This is what is given in all culture reports and have to be interpreted. It stands for minimal inhibitory concentration, and it's a minimum concentration of the antibiotic required to stop the growth of a microorganism. When we test for sensitivity, what we do is we take serial dilutions of antibiotics, usually in a binary fashion 2, 4, 8, 16, 32, and identify at which concentration the microorganism is fully inhibited. Different antibiotics have different MIC cutoffs, and generally they are derived from the fact that what concentration which those drugs reach in the body if we give them at the standard dose. Three values are of significance, which is the CMAX. This is the peak concentration an antibiotic achieves. The AUC, the average concentration over a period of time. So antibiotic builds up, plateaus, and then falls. We look at that. And then the duration above the MIC. How long was the antibiotic able to achieve that? Ideally, it should be 100%. But that's hardly seen. We want the CMAX to be something around 8 to 10 times of the MIC and the AUC around 4 to 5 times. And ideally, as I said, for 100% of the time. And the only way to know this is by doing therapeutic drug monitoring. For antibiotics which are dependent on their efficacy on the CMAX, we give generally high dose once daily dosing like an aminoglycoside. And those which are dependent on AUC, we give a longer infusion time. We dose them more frequently. And when the MICs are high or even for resistance, we have the option of using a higher dose because this will achieve a higher AUC level. And for keeping them at the greater period of time, we increase the frequency of administration. The lower MIC values, the more likely effectiveness of an antibiotic. And above MIC, we say it is resistant. The MIC is based on the serum concentration. The tissue concentrations may be higher or lower. So this should be remembered. If an antibiotic doesn't have renal penetration and clearance, like a TG cycline, it would be not of use even if the microorganism is shown sensitive because the renal concentrations will be poor. So always consider the site of an infection when an antibiotic is considered. Sometimes we also get this intermediate range. The sensitivity report showing is intermediate. Clinically, it means that probably the MICs are high and the drug might work if you optimize the PK/PD. Now, how to optimize? The therapeutic drug monitoring is one of the best ways. We have been doing it for two antibiotics, aminoglycoside and vancomycin, mainly from probably the toxicity point of view, but they are also, efficacy is dependent on the optimized PK/PD. Aminoglycosides, we look at the CMAX, check serum levels 1. But with vancomycin, we have to check the AUC. AUC is a more difficult calculation to make. So what we did was, we did a pre-dose level when steady state had been reached. So after maybe 2 days of vancomycin. But then we found out that that pre-dose level may not correlate to the AUC. And that brought about a paradigm shift in vancomycin monitoring. It's advised to check it twice, once 2 hours after the dose and then just before the next dose, and then extrapolate based on some standard algorithms and to find out what was AUC achieved. Therapeutic drug monitoring may be considered when we have multi-drug resistant organisms in the presence of sepsis, organ failure and extracorporeal therapies, because in all of this, the volume of distribution, the metabolism, the clearance is affected, and we are dealing with MDR bugs. We would really like to have a very high concentration of the antibiotic. What about this post-antibiotic effect? Sometimes it is seen even at subtherapeutic, below MIC levels, an antibiotic still maintains its effectiveness. Aminoglycoside is a classical example. Probably it's cidal at higher dosages, and when the concentration falls, it probably becomes a bactericidal, So that could be one correlate. And then we also have this another issue of inoculum effect. So if we have a very large bacterial load, sometimes we can overwhelm, and there we might require a higher dose of an antibiotic. So MIC till now remains the standard by which we determine sensitivity and resistance, generally done by two methods. One is a gradient method called E-strip method, and then other dilution method you can have in solid or liquid media. And then the standard cutoffs which are given. And when we are dealing with organisms with higher cutoffs, maybe above the resistance levels, the only way we can make the antibiotic effective is by optimizing the PK/PD parameters.